So Jim, are there any major, except for the transperitoneal approach, are there any glaring differences? If you were to debate
Can you
Ronnie
rotate
on
the
this,
bed
what would
away
you
from me
say?
now,
I
please?
mean, we discussed the big
Rotate
needle.
the bed that way?
Right.
But what differences would you do in your approach?
Well, I think we do things similarly. I mean, I'm a big fan of the fourth arm for transperitoneal surgery. I like the fourth arm.
What would you use it for?
Well, you can retract the kidney. You can, if you have bowel in your way, you can hold the bowel back if you need to. You can retract the liver with it. So let's say you don't want to put a liver retractor in. You can put the fourth arm in there to hold the liver back. What I like it for, though, is actually getting good stretch on the you can get good stretch on the hilum. It facilitates doing a hilar dissection. So when you have only 3 arms, when you do the hilar dissection, your left hand, in this case, is holding up while you're doing one-handed dissection on the hilum. If you have the fourth arm in, you can actually hold up on the kidney, and then you can use 2 hands on the hilum, which is a safer technique.
Especially when you're trying to
I've often heard that the best one-handed surgeon is not as good as the worst two-handed surgeon. So if you have 2 hands, you're going to do better. But I also like it for those cases where the tumor is kind of lateral. And this tumor was very much anterior, and you could see it very nicely. But some of those tumors are on the back side. You can take the fourth arm, you can pull up on the fat, and it rotates the tumor towards you. So again, you have this on-face view of the tumor. If I had the fourth arm in that case, I would probably have grabbed it and pulled it up. And so I would have the tumor tilted towards me more. I would have seen the back of the tumor as well, probably the whole time I was excising it. I mean, it's a slight difference, but it helps you do that. So I think the fourth arm is helpful. But the problem is, where do you place it? And where you place it, and I can talk about it, but it's probably best to show on a diagram. You've got to put the fourth arm out laterally near the hip, because if you put it medially, it just doesn't work. It hits the hip. And then the way Ronnie's got his trocars, he's got his left robotic arm way out there laterally. So that's what most people do, and then they end up putting the fourth arm medially because of that, to avoid that left robotic arm, and so therefore it doesn't work. But the long and short of it is, you've got to put it in a good place where it's not going to conflict. I think he had excellent ischemia. I think the Doppler technique, I think he's very good at it. I would have probably had a hard time convincing myself that I had really good ischemia. I would have just dissected out the vein on top just to make sure there's no vessel there. A slight difference. I wouldn't have found it in this case, obviously, and then I would have been fine. But I would have also given ICG to confirm I had complete ischemia. My experience is that the selective the ability to see a tumor differential, to see the tumor being different from the green, is very limited. It works very, very infrequently. So therefore, I've gone to using ICG, the Firefly, for selective arterial clamping, or when I'm going to clamp the complete hilum, I give a dose right after I clamp to confirm that I have complete ischemia of the kidney. So if I clamp the hilum and the kidney is completely dark, then I know I've not missed an artery. And I would say for somebody early in their experience who does not want to do a complete hilar dissection, it's a great technique, if you have Firefly available, to confirm that you're not going to have a missed vessel. And Ronnie's experienced, and he can tolerate more bleeding than people that have not seen that. And I would say using Firefly in that way is a great way to confirm that you have complete ischemia.
What about defatting the kidney? There was some discussion in the chat room about defatting the kidney. Do you totally defat it? And if not, do you ever find the fat gets in your way?
I defat basically what I need around the tumor. I don't defat the areas away from the tumor. I would have defatted more. I don't know if you saw Ronnie, he had fat on the top part of his rhinorrhaphy. It was very hard for the clip to get between the kidney and the parenchymal edge and the fat. I would have done more on that surface just so that I would have had more space to put my stitches. So you've got your margin of resection, which is 5 millimeters depending on who you are, and then you need another centimeter to 2 centimeters around that in order to give you enough space to put your needles in for your rhinorrhaphy once you're done. So I do more fat removal, or at least exposure, than what we saw today.
Talk to me a little bit about one of the things is the ear seal, and the fact that you can suck without losing your pressure. That's pretty significant. Talk to me a little bit about your experience with that.
Yeah. So what we have found is that when we were doing our cases without ear seal, we had to be very aware of how much suction we were doing. In fact, we would see like the abdomen fall a little bit, when they were suctioning with regular, at 15 millimeters of mercury pressure. But this is the biggest advantage of air seal, I think, and this is going to be very clear to people that do laparoscopic surgery. When you do laparoscopic surgery and your pneumoperitoneum falls because you've lost insufflation, the trocars fall with the abdominal wall. But when you do robotic surgery and you lose your pneumoperitoneum, those trocars are fixed in space. So when the abdominal wall falls, the trocars are falling away from the abdomen, or the abdomen's falling away from the trocars, which means you have to re-put your trocars in every time that happens. That's why air seal for robotic surgery is a huge advance. It's because that issue of having your trocars move because they're fixed in space, that goes away. I mean, I never have to deal with that at all. So we found that to be a huge advantage for robotic surgery. I would say subjectively, we don't have a study to prove this, so subjectively we've seen our patients have less pain, less shoulder pain, less, the shoulder pain that we classically see, we've had that to be less. And we've run at lower pressures. And we know that running at lower pressures means physiologically there's better things happening. There's better return to the heart for preload. There's less renal vascular compromise, which for a partial nephrectomy is going to be important. So we know higher insufflation pressures have physiologic downsides that we can avoid with running at lower pressures.
And is it just the one trocar then, or do you? Because I saw it looked like the two trocars.
No, he had one regular and he had one air seal. Yeah, you really only need one air seal trocar, because of the way it's designed. The flow is extremely high, and you don't have to do more than one.
Right.
Although I heard they're doing two for certain procedures, right? No, not yet. Okay.
And do you use it on your prostates as well?
Yeah, I use it on all my robotic procedures for the same reason. We can run at lower pressures, and we don't have to worry about suction.
So did Ronnie convince you to use the big needle? We saw that the pulse at 50-50. We want to know about the Dr. Porter. What did he convince you yet?
Well, you know what he convinced me? I do like his first layer rhinorrhaphy. And I would say of the two layers, that's nice. The most important layer. The outer cortical layer is probably not as important as that inner layer. And I really like, like I said, I used V-Lock for a while. I went away from it because I didn't like the characteristics to the kidney. But I think that's a very good rhinorrhaphy, and it does facilitate early unclamping the way he does it. And I think that's an advantage when ischemia is really the concern for a lot of people. It
was a bit of a misnomer of one layer because it was more about 12 layers.
Oh yeah, no, there's several layers, and I think most rhinorrhaphies are several layers. I mean, I personally do 3 layers right now. I do a individual suture layer on the collecting system in large vessels. I do a running monofilament layer, pretty much at the same level that Ronnie's doing it, and then I do an outer cortical layer. I don't go all the way down as far as he does. I probably go to the medullary portion, and my sutures are coming across at the medullary portion, and I found that to be, first of all, it brings everything together completely. I don't have any exposed cortex, which to me means no oozing. I don't need a hemostatic agent, but also I'm getting compression of the defect underneath. So, but I do think coming off and getting those arteries beforehand is a very good thing.
So you would have gone in individually and sutured those collecting systems with individual sutures?
Yeah, and I do back and forth. If I have a large number of them, I'll run it. But if I have just one, I will do an individual closure of that. And I run that closure, and while I'm doing that, I'll try and grab some vessels that are around there, because very commonly there are some arteries right around that collecting system defect, and I'll try and include those arteries in that closure.
Is there anything different you do from the retroperitoneal approach that, in terms of closing your ports? Do you close your ports?
Mm-hmm. Yeah, we do an extraction incision, so he's going to have a pretty good size extraction incision for a 6 centimeter tumor. So we're obviously going to close that. I do the same thing retroperitoneally. I use a dilating blunt trocar for my 12s. I don't close the 12s, and I don't close the air seal assistant trocar. I have never seen that to be a problem yet, so we haven't closed that. So it's really just my extraction incision, and I close that.
Okay. Talk to us a little bit about your post-operative course. Ronnie talked about it and has published on his care path. Do you have a similar type of care path?
Yeah, we do. We're really aggressive about getting patients up and walking the night of surgery. And I think before the hospital stay, I think one of the key things is setting expectations for the patients. If you're going to get patients home sooner, if that's important to you in your hospital, you got to do that in the clinic when you meet the patients. You got to do it right before surgery in the pre-op holding area, and they expect that. And they will not be surprised when they're getting up and walking that night, or they're drinking liquids. The intent that they're going to have a regular diet either that night or the next morning. It's not a giant surprise to them. It's the patients you tell they're going to stay 2 or 3 days in the hospital that are not really going to do those things. So you need to set the expectation early on. But I would say our pathways are very similar. We like IV Tylenol. We like the IV acetaminophen. We think that's a nice drug. And I think Toradol is fine, but we've kind of gone to the IV Tylenol. We give oxycodone only, so we can give Tylenol around the clock. So once we're off the IV Tylenol, we're giving oral Tylenol around the clock every 4 hours. And they're getting oxycodone separately if they need it. We send them home with oxycodone. We encourage them to take Tylenol first. and I would say the vast majority of our patients can avoid taking oxycodone at home. They'll take a few at most, but most of them can avoid it completely, and most of them go home day one. Even the transperitoneals. My biggest patients that I had the hardest problem getting out of the hospital were transperitoneal patients, and I think because of the reasons we talked about. Blood in the peritoneum is a big irritant, and those patients will have an ileus. I think left-sided cases more than right-sided cases, and so we were having a hard time getting those patients out. But the more we set the expectation of getting them out and eating, and the more I think meticulous we are about hemostasis, the better they do and get out of the hospital.
So let me ask you about IV Tylenol. We started using IV Tylenol. I thought it was a great drug. Our hospital is now giving us trouble because of the expense. Are you guys seeing any pushback from the hospital?
Well, we've kind of put this into the bigger picture with regard to, what's a hospital day cost you? How much is that? So, it's a trade-off. I think definitely it's more expensive than Toradol. It's more expensive than narcotics. But if patients are able to eat faster, they're going to get out of the hospital sooner. And I think the narcotics keep them from eating. And I think it makes them loopy. They don't want to get out of bed when they're narcotized. So we see this as a trade-off in the positive for our hospital.
So why not Toradol? Are you concerned about renal function?
That, and I would say the analgesic effect that we've seen, I think, is actually superior with the IV Tylenol. I don't know the literature on that, but I would say in our hospital, our anesthesiologist